Okay, welcome to the Duke Spine Institute, Surgery Center Viera live stream. And our patient here is a patient who has a history of having back problems, as you can see shortly on her x-ray if you haven't seen it yet. She has had fusion done elsewhere, not by me. And just a little injection, little medicine. Just lay still. You're fine. See, even injecting pain medicine under the skin can be uncomfortable. So she has a history of fusion that was done by another surgeon. You could see on the x-ray at L4-5 and L5-S1. And now she has what's called adjacent segment disease, where the discs above and below the fusion are problematic for her. Okay, that's better. So on the left side, we're doing 2-3. Everyone agree? Agree, sir. 2-3. So got to aim north a little bit more. Shot. All right. I'll give her some more num-num. We need some numbing medicine. So today we're going to be treating the L2-3 and L3-4 discs. These are adjacent to her prior fusion. Adjacent is in above, next to but above. We're also going to take out her spinal cord stimulator. She has a spinal cord stimulator generator that was put in because the fusion didn't really work. And she said, it's not working. Please take it out while you're there. I said, absolutely. Happy to do that. Shot. All right, now that I'm hitting some bone graft. Shot. Definitely hitting some kind of graft. Shot. Let's get an AP. I have a feeling that's going to be too medial. So right now we are navigating down to the part of the spine we're trying to fix. Yeah, you're right. It is 3-4, isn't it? Let's just see what we got. Okay, yeah, we're too medial. And show us the spinal cord stimulator leads while we're there. Let's take a little inventory of what we've got. So we've got the leads for the stimulator there. Somebody else put in. Show us the generator. Looks like a little computer. And then she has these cages they put in the front. And then she's got the screws and rods in the back. Wow, what a mess, huh? All of that, and the poor patient's still suffering in pain. So we're going to try to fix that for her today. All right, let's go back to a lateral view. So we're going to be left L2-3. Shot. That looks good. Hitting bone. Shot. Lay still. Shot. All right, getting closer. Shot. Almost there. Lay still. Where do you feel that?
Where are you feeling that? In your back? Where are you feeling that?
AP, that's where herniation is, getting close to the herniation. Perfect. All right. Nice view from the front of all the hardware that was put in.
There you go.
Unfortunately, it's becoming all too common to see patients with huge amounts of hardware in their body from surgeons that just are hardware lovers, you know. They love to put all that stuff in.
Okay, where are you feeling that? Where are you feeling that? Where? feeling it? Tell us where. In your back? Feeling that in your back.
Yeah. Yeah, that's one of the bad discs that we're going to fix for you. You're okay. Lay still. You're doing great.
Keep your head still.
All right. Poor thing has been in so much pain for so long. Let's go ahead. We're not doing that yet. We're going to the right side, right?
Oh, you're right.
Hey, dude. Safety net. Take your time, Jordan. Let's get that next disc looking good. That better? All right. Lay still. You're doing great. We're going to give you a little more numbing medicine. Don't get upset with me. Yeah, I know. Just a little needle poke and you see the reaction. Yeah, that's just numbing medicine going in. Relax, relax, relax.
Keep your arm still.
You're okay. You're okay.
Keep your arm still.
Yeah. You're all right. Did you already numb up this line?
Yes.
Yeah, we literally just put the needle in for the numbing medicine and poor thing is in so much pain. Lay still, you're doing great.
You're doing fine, don't move.
All right, so you see that pedicle there of 3? I wonder if we can fix that with some wag. Well, I guess that's the situation where num isn't so good, right? It'll get better. It'll get better. All right, you need to fix it.
Give it 7 minutes.
Yeah, right? There we go. There we go. That's perfect, Jordan. Let's keep that. All right, so you're okay. Lay still. All right, so we're going to go for the number 3-4 next. Shot? You're all right. You're all right. Shot? You're okay. We're almost done.
We're almost done.
Beautiful. Yeah, we're almost done. Poor thing. Poor thing. You're doing good. Lay still. I need your help. Where do you feel that?
Where are you feeling that? Where are you feeling that?
Where do you feel that, dear? All right, we do need her awake for this part. So we're done torturing the poor thing. Yeah, we're gonna do our discogram next. Dr. Berndes gave her a little bit more medicine to make her more comfortable, but we're now ready. So when you want to make her up, we're good. Now, while we're waiting, is she gonna be a little while? Should we take the stimulator out?
Yeah. Yeah?
But there is Bovie involved. All right, Luis, go ahead.
Because we need it.
You want to wait? Okay, we're gonna wait.
Because it's going to take some time to suture.
Oh, we don't have to super it.
It's okay. How you doing? Whatever you want.
All right, no, we're good. We'll wait. I'll take your advice. Folks, lay still.
Can you open your eyes for me?
So she's got screws and rods on both sides. She's got a generator right here. You're going to see that in a minute when we open it up. And she's got a fusion right up to about here. I was never an artist. Now, just above the fusion is a disc, a joint that's painful, I believe, and then one above that that's painful as well. She has herniations here. This is L2-3, and this is L3-4. She's just calming down a little bit. She's almost ready for us. We're going to give her a few more minutes. Everybody good? Well, I like to hear that. Engaged to your work? Yeah? All right. So you can see on the x-ray picture our needles are in really good position at the 2 discs above the fusion, which I believe are the cause of her back pain. So, who wants to make a bet since we're waiting? Which disc is going to be more painful? You say L3-4. What do you say, Luis?
Let me see.
You want to reserve judgment?
I see, maybe 2-3. I would say 2-3.
Jordan?
Yeah.
2-3. So we got a 2-3, 2-3, 3-4. Huh?
I'll say 3-4.
3-4. Okay, this side of the room is 3-4. I'm waiting. I'm asking you last. Go ahead.
I'll say 2-3, I think.
Smart. There we go. You guys weren't paying attention. I think 2-3 is going to be it.
Can I have a vote?
Yes, of course.
I believe I'll go 3-4.
3-4. Oh, got to be different. No, you're 4-3. You're 4-3. That's right. I think it's going to be 2-3 as well. But hey, I could be wrong. The 2-3s have it 5-3. The 2-3s have it 5-3. Let me know when you're ready.
Hello? My friend, can you open your eyes?
So for those of you who don't know what we're talking about, we're going to be testing her 2 painful discs in just a moment. And whenever we test a painful disc, we inject a small amount of dye. Lay still. You're fine.
Can you open your eyes for me? Can you open your
And
eyes?
we do that because we want to stain the degenerated nuclear material within the herniation. We want to stain it blue if it's degenerated. We also do it to see just how much pain those discs are really causing the patient. So they give us a rating on a scale of 1 to 10, 10 being the worst pain, 0 being no pain. Are you comfortable? All right, Dr. Duke here. Everything's going really good. We're going to put you to sleep in a minute. And then when you wake up, we'll be done, okay? Sound good? She's not quite there. I need to give her just a little more time. Normally, when the patient's ready for the test, they can carry on a conversation with you. Hey, lay still. You're doing great. Don't move around so much. Is her neck comfortable? Arms comfortable? Everything's good?
I'm happy with the position. Hello? How are you? Can you open your eyes for me? Can you open? Good. We're going to ask you some questions, okay? Are you having any pain right now? No pain?
Can you lay still? Lay still. Can you hear me?
Can you hear Dr. Duke?
Still a little foggy. Speaking of fog, there was really a lot of fog today on my way to work.
Hi. Can you open your eyes for me? Can you open?
I have a bad feeling that both discs are going to be 10 out of 10. Nobody's going to know. You guys are all going to be right. All right, so while we're waiting for just a few more minutes, let's show the audience our tools of the trade. The whole surgery today, folks, is going to be done through a small tube called a tubular retractor, endoscopic tubular retractor. Lay still.
Can you open your eyes for me?
You sing so beautifully. You remind me of my time growing up in California. I used to go out and listen to the coyotes at night. So the whole surgery will be done through this tiny tube. And we're going to be putting the endoscope through there. I'll show our audience the endoscope while she's almost fully awake. So the endoscope has certain parts. You have the actual endoscope here with a long channel, and it's a series of lenses that transmit light and an image from the tip all the way up. And then it goes to the camera. This is a high definition camera. You have a light source, the blue, you have irrigation, and we have a port, one port that we work through. All right, are we ready? Are you awake? Hey, I need you to talk to me. Can you talk to me? All right. You're okay. Are you comfortable? Are you comfortable?
How are you? Can you open your eyes for me? We're going to ask you some questions, okay? Dr. Dukes here, we're going to ask you some questions, all right?
What do you need to do?
Huh?
Good?
Yeah.
Putting a little
Try
bib
not
here.
to move, okay?
Let me know when you think I can't do it. Let me know when she's ready.
Can you open your eyes for me? Okay.
All
We're
right.
gonna ask you some questions, all
Are
right?
you comfortable? How bad is that on a scale of 1 to 10?
What number was that? 10?
How high did that go? What'd she say? How high did that go? 10. Is that where you get your back pain? Is that where you get your back pain? Is that where you get your back pain? Is that where you get your back pain typically? Yes, thank God. All right, concordant. All right. Relax, you're okay. Everything's okay. So we got a 10 out of 10 for the 2 3s. Who are the 2 3s? So we can't be wrong unless she goes above 10 for the next one. All right. She's better now. How bad is that on a scale of 1 to 10? 10. All right, sweetheart. You get to go to sleep. Let's put her to sleep. Is that where you get your back pain? All right, so everybody's right today. Lay still, and we're going to put you to sleep. You're going to feel a little burning in your arm. That's the medicine going in. All right. Well, I will tell you this. I see a lot of patients with different levels of that's just the medicine, with different levels of pain tolerance. Some have absolutely no pain tolerance, and others have very high pain tolerance. Poor thing, the way she's wired, she doesn't have very much pain tolerance. I need some light.
Light, please. Ready? Thank you.
I'm going to make a small incision, 7 millimeters. The whole surgery will be done through this tiny incision. Shot. Remember, we are first starting with the left at L2-3 disc for the degenerated disc at L2-3 that's causing her pain. You saw that she had 10 out of 10 pain at L2-3 and 10 out of 10 pain at L3-4. So the good news is when we're done, all that 10 out of 10 pain should be gone. Shot. We're going to use the x-ray to take pictures as I move the dilator forward. I can actually feel a considerable amount of scar tissue from her fusion. And I think we're going to be okay. Shot. I've got to advance with the mallet. The mallet allows me to give just a little bit at a time of energy to advance the dilator. Yep, very nice. Her bone quality seems to be good. I don't see any evidence of osteopenia or osteoporosis. Yep, perfect. So we're starting to go in to 2-3. So now that she's asleep, she's relaxed. Her back muscles have relaxed. She's not tightening up, so the bones can separate at the disc. It allows me to get into that disc so we can fix it. You can see the tip of this tube. It's now in the disc, in the annular tear and the herniation. Show us the tip of the tube. Shot. Do a shot first. Yeah, right there. Yep, so it's perfect position where we want it in the back of the disc, right where the annular tear and herniation are. Because the surgery doesn't require removal of any of the bone or ligaments that are natural to the spine to stabilize the spine, we're not actually creating instability. You doing all right?
Yeah, sorry, I'm
All right. So the nice thing about this surgery is we can fix the back pain and leg symptoms without actually making the spine worse, which all the other open surgeries do. All right. Any questions from our audience?
No current questions, but we do have a comment from Miran on Facebook.
Of course.
And they said, "Good evening, Dr. Duke. Thank you for sharing your work. I'm amazed how you can multitask so perfectly, educating, talking, thinking, and operating it all at the same time. This is one heck of a skill."
Thank you so much. I enjoy teaching. And what better way to teach than while you're actually doing? So thanks for being here, and I appreciate the positive feedback and the energy. We're all pretty tired. The first case we did today was really a difficult case. All right, here comes the first little piece of herniation. Let's go ahead and show our audience, why do lumbar disc herniations actually cause so much back pain? What's the mechanism? I'll give you a hint, it's inflammation. But watch the video and you'll see what I'm talking about. By the way.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
Almost 50%, right? That's 15, 16, 17, 18 joules. Welcome back. So you're able to see just how a herniated disc can cause so much pain for people. It's really a tear that happens in the back of the disc, and that tear gets inflamed, just like a pimple in your face gets inflamed, or any inflammation in your body. And that area of inflammation is always going to be painful. So you can see the grabber that I'm using is just not very effective at removing the herniation. I grab and grab and grab, and it just doesn't really work. And that's true for all grabbers in neurosurgery. They're not wonderful, and they're really limited because their lever arm, basically the fulcrum that you're using to squeeze the teeth together, is very short between the teeth. Therefore, you can't generate a lot of grabbing force. Even though the handle is long and designed optimally for generating grabbing force, you just can't grab with enough force. So You can see the lasers working. For those of you who haven't seen this before, the laser fiber a little bit overexposed. Let's bring the light down. The laser fiber itself is about 1 millimeter across, side to side. And it's made from glass, very high quality, but that's a little bit too dark. I'd say 1 click up. Yeah. I think we just have some dye and blood making the picture not great.
You, increase the brightness a little bit. Down there, the light.
I think we're okay.
Are you sure?
Yeah. I don't know that it's a brightness thing, because the problem is when you get blood in the water, of course the sharks come, but you also have glare back.
Thank you, Jordan. So Jordan,
Oh yeah, that's a,
can you let I don't know, I need this one and that one for now, and then when we open, then I need the other stuff. You know what I'm saying? So these two, yeah, for now, and that one, yeah, thank you.
any questions?
No current questions.
Let's show our audience just how the Duke laser disc repair actually works.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
All right. We're working away here, removing the herniation pieces little bit by little bit, because that's all we're getting. It's pretty typical to have small pieces come out. We've had some big ones in the past, but generally speaking, most of these herniations come out piecemeal, which just means a little bit at a time. Pieces. Any questions from our audience about the surgery that we're doing and how it works, why it works?
We have a question from Miran on Facebook.
Sure.
And they asked, do you track your patient success rates in eliminating pain over the period of 5 years? Would you say that if the patient doesn't herniate again due to misfortune or because they didn't follow post-op advice, they will be pain-free when the disc is treated, considering that there are no other issues like that?
Yeah, great question, Miran. We do track our patients. Not all of them, but we've looked at the Duke laser disc repair patients at a minimum of 5 years follow-up. Turns out that there was 6 years on average. And what we found was that they had 95% of their back pain from before surgery was gone, and 95% of their leg pain from before surgery was gone. So that was 6 years after surgery. There is really no follow-up in spine surgery that long. It's one of the only studies published that has long-term follow-up for surgery for back pain. So there is no better treatment. Artificial discs don't have that good of results. Fusions don't have that good results. laminectomy, interspinous devices. There's nothing in the world you can do to the spine that has as good results 6 years after surgery than the Duke laser disc repair. Now, that said, there aren't many places that track long-term follow-ups. It's not typical. The only way we did it was by telephone, calling patients and finding out how they were doing, asking them, how much of your pain that you had before your surgery did we get rid of in your back and of course your leg, and recording their answers. So, yeah, great results. That's why we do this surgery. We don't do Duke laser disc repair for short-term results. We do it for long-term results.
We have another question.
Sure.
This comes from Heriberto on YouTube.
Hello, Roberto.
And they asked, what are the risks of doing a disc bulge removal? For example, in the lumbar area, for someone who is 21 years old with congenital stenosis who's not overweight.
Hi, Roberto. The risks of this surgery for a disc bulge are lower than any other surgery you can do for your same problem. The risks associated with open back surgeries like fusions, laminectomy, spinous devices that don't work, those risks are about 10 to 20% complications. With this surgery, we've had 0 complications from the surgery itself. So there is no surgery that gives you lower chance of complications than the Duke laser disc repair that you're watching right now. Now, what are the complications that you could have? Well, like any surgery, you can die during the surgery, can be paralyzed, nerve damage, spinal fluid leaks, infections, heart attack, pneumonia, stroke. All of those things are possible. All of them. Organ injury to your intestines or blood vessels. So there's a lot of bad things that can happen with surgery in general. But thank God it's very rare. And in the case of the Duke laser disc repair, this particular surgery, we've not had those complications. There. See the herniation that just came out? The blue? Great questions from the audience. Appreciate it. I'm almost done on this disc. Going to take a look around in just a moment. A lot of this is scarred and calcified from years of inflammation going on inside the disc itself. Let's see. Just a little bit more to go. Again, we have a very collapsed disc, just like last time, last surgery. I don't really see anything more. Maybe a little bit here. Everything okay over there?
Oscar, you good?
All right.
Lights
Let's
on,
see if we
please.
can see the nerve.
1 second, 1 second. Sorry.
Actually, you know what? There's a little bit right there of herniation, just there.
Thank you, Sarah.
Let me get that. Huh. So I just turned the endoscope for a second and looked over there. Yep, there was a little bit of herniation. That looks good.
Lights on, please. Thank you.
Any questions?
No current
I need
questions.
irrigation. Is that open, you think?
You clean it, right? You clean that.
All right, it's good. Yeah, it's good. Is the suction off for oh, we got it? You're okay, sweetie. We're just cleaning up. All right. Yeah, I think a lot of this is mm-hmm.
Jose, can I have blue towel, please? Thank you.
What we call supratentorial cortical, derived from the brain, the cortex of the brain. All right, you want to switch places, or what do you want to do? Here, I'll numb that up. Come on over. Gonna give you a little more numbing medicine. Don't get upset. So for those of you who are watching from the beginning, we're actually going to be taking her stimulator generator out next. So we've got the next disc, and then after that, we're going to take the spinal cord stimulator generator out. All right. Skin knife. Yeah. We're going to do our second 7mm incision on the other side. Dilator. Remember, the dilator has a tapered tip. It gently spreads tissues. Yeah, her pain threshold is very low. That's one thing I've noticed about her. That's for sure. And that's okay. That's just how she's wired. Everybody is different. There's nothing abnormal about a pain threshold being lower, but that's how God makes each one of us is different. So, and like I said, throughout the years of doing 1,600 of these surgeries, we see people who, like, they can't tolerate even getting the needle put in for the local anesthetic. And then you have people who are super stoic and tough, and they just lay there and it doesn't bother them. And everything in between. Like when I go to the dentist, they're going to work on my teeth, you know, fill a cavity. They numb up your gums with that needle. Yeah, it hurts for a second, but You just grin and bear it. But then again, you're conscious. These patients are quasi-conscious because we're sedating them, so they're not quite there 100%, and they startle easily, is what Dr. Berndes says. They startle easily. So it's nothing to do with them. It's just a lot to do with the medicine we're giving. It works on their brain to make them sleepy. Okay, disc number 2. And then after this, we're going to take out the spinal cord stimulator.
The better on the other side, please. Thank you.
Any questions from our audience?
No current questions, but we do have a comment from Heriberto once more on YouTube.
Hello, Roberto. Thank you.
He, from answering his question from before, he says, "Thank you very much for your answer. I've sent in my MRI images and report to your official website. I hope for the best. I'm young and I really want to get better to be able to work and make a living."
Of course. Yes, Heriberto, I agree with you. So many people suffer with back pain for years and years, and it really robs people of the quality of life that they have, you know? Nobody wants to live in pain. Pain is so incapacitating, and unfortunately many people think it's normal, you know, live with pain. There's nothing that can be done to fix it. But now we are able to cure back pain and neck pain. It comes down to having the right diagnosis and the right treatment for that diagnosis. So now this disc is quite interesting. It's different. You can see there's a tear. You all see the tear? I'll show you. Left, right, and the tear is in the middle. And the blue stuff is the herniated nucleus pulposus, stuck inside the tear. The tear is within the annulus fibrosus. This is why the patient has so much back pain. It's the tear and the inflammation within the tear. The evidence of the inflammation is the blue staining of the nuclear material. It's normally white. The white normal nucleus does not stain blue. Only when it is acidic, only when its pH is less than 7.4 will it stain blue. And how do you get the pH less than 7.4? That comes from inflammation that modifies the protein structure of the disc.
We have another question.
Uh-huh.
This comes from Heriberto once more on YouTube, asking, "Do you do blood transfusions with this surgery?"
Do we do blood transfusions with this surgery? The answer is no. I'm not sure if you're asking if we do a transfusion for because the patient loses blood, or are you asking if we do like PRP, stem cells, for treatment? Blood transfusions are only needed when the surgeon is very sloppy and loses blood. I've never had to do a blood transfusion in 26 years of spine surgery. Even with my fusions, I never did a blood transfusion. The most blood I've ever lost in a spine surgery was 500 cc's. And the average blood loss for a fusion surgery when I do it is around 100 cc's. You need to lose 2 liters of blood basically to do a blood transfusion. Maybe 1,500 or 2 liters. 1,500. So I have never come close. If you're a good spine surgeon, you'll never lose that much blood. But there are a lot of surgeons who don't know how to control the blood loss during surgery, and their patients almost bleed to death. And for some reason, those surgeons think it's okay. But I don't think it's okay. There's the tear. I got 5 minutes on this part. And we got to do the stimulator removal. Do you see the incision on the thoracic? Luis?
It's around.
Did you see it?
No.
You're supposed to see it and mark it before. Next time, okay?
Yeah.
Let's see what I can do. Sure. Look at all this inflammatory scar tissue. Just a giant ball of it. This whole thing there. Just about finished. There's the tear. So no, Alberto, there's no bleeding with this surgery. It's just a few drops of blood, and there's no transfusion. I've never done a blood transfusion for spine surgery. It's not necessary. I could literally do any spine surgery in the world and not need a blood transfusion. Why? Because there's things you can do as a surgeon to make sure the patient doesn't bleed. The only time you don't have the ability to do that is when the patient is a trauma or an emergency and they are on blood thinners like Plavix or Coumadin, and they come, or they have a bleeding deficiency where they have blood clot. They don't form blood clots, and they bleed. They can bleed to death, or if they have a platelet disorder, you know, thrombocytopenia, they have too little platelets. But those are always emergency surgeries, and under those circumstances, the surgeon has far less control. So does the anesthesiologist of the bleeding. But under these types of surgeries, we control the blood pressure very nicely, make sure the blood pressure is not too high, and that because the blood pressure is not high and because the incision is so small and we're not cutting through blood vessels, you don't lose much blood at all. It's very important to control the blood pressure though during spine surgery with the help of the anesthesiologist. We've been doing this outpatient surgeries now without blood transfusions or hospitalizations for 10 years at Duke Spine. 10 years without the hospital. So I believe spine surgery can be done much safer outpatient than in the hospital. That's why we do it here at Duke Spine outpatient. All right, we're almost done. Any other questions?
No current questions, but we do have a comment from Heriberto once more, and he said, "Awesome, thank you. No more questions from me. You do such an amazing job. You have no idea how much I appreciate your answers. I'm young and lost, so this helps me like you have no idea."
Sure. Don't worry. It took me probably watching 10 or 20 surgeries before I understood what was happening. So it's normal to be a bit disoriented, you know, when you're watching. And of course, over time, as you learn the anatomy and you learn where everything is and what everything is, it gets easier. So don't feel bad in any way. We enjoy having you here. So I'm almost finished fixing this disc, and then I'm going to go to the spinal cord stimulator removal. Way to pay attention, Omar. Yeah. Good job. tell you, my feet are starting to hurt. A lot of standing today, you know? Huh, you too? Yeah. All right, look, a little bit of herniation right there. And that should be it. Grab her. That was north, just by the nerve root again. That's why I always look to make sure we're not actually leaving anything behind. We don't want to leave behind, like a piece of herniation somewhere. We say north, we're talking and referring to towards the head of the patient, the cabeza. That's how surgeons talk. We say north, we say south. What's up?
Just trying to get it to the.
I already engaged.
You did it? Okay. so
Yeah,
it should be
it's
okay?
already in there. Should be fine.
Well, just in case you need more, go for it.
Yeah. So before we open, I suggest Jordan take a picture where exactly are the leads. Usually they go 8, 9.
No, you saw it.
Is that okay?
I'm not worried about that.
Well,
No, they're either going to come or they're not. You know what I mean?
I know what you mean, but you asked me about thoracic. That's what I'm saying. Like, that was
All right. This is a disc herniation that doesn't want to finish. It likes getting attacked by the laser. Come on. Boy. Can see the epidural fat there. How's the irrigation? All right. That looks pretty good. Maybe one more time with the laser and we'll be done. Another minute, I think. And then we're going to get this stimulator out, the generator. Looks good.
lights on, please. Good.
Grab her.
So I know.
Luis just likes saying that.
What?
Huh?
Don't grab so hard. I don't know why, but I just keep, it's almost like it's falling down into the wound. Maybe it's just the way the new power settings work. God damn it. Every piece of fucking herniation has to sit there and make me grab it out. Let's go up on the power a little bit.
You have to stop and then. Okay, go up. Power up there.
Go up to 30.
No, no, no. So go to 3. 3?
3.
Yeah, and then 15. Yeah. There you go.
Let's see. I'm trying to assess that. I think it might be better. I'm not 100% sure. All right, that's it.
Last one, please. Thank you. Squat up. Thank you.
Kinda glad we don't have 5 cases today.
Huh?
Kinda glad we don't have 5 today.
I don't think
Just 'cause of the
we could do 5. Not when we have a 6 level. You know, that's like 3 cases itself. Really, we really did like 4 cases, maybe 5 today. If you consider all the discs and then the spinal cord stimulator. You guys see all the pieces of disc material here that came out. You guys see this, Henry? All this stuff.
Yes, we do.
So those are all the little pieces.
Now we're gonna need the other suckers. Just so you know they're on the corner.
All right, we're done
I need
with the endoscopic procedure.
somebody can start
Next, we're gonna
pulling the
take out this young lady's stimulator. You have a Bovie?
We have a bottle, yes, sir.
Let's see a skin knife, a Bovie, and I'll do this while you, and a retractor like a Wheatie. So what I'm gonna do, folks, I'm gonna open her up back here, and you're gonna see the generator. It's gonna be grayish metal. I don't use that. I just need a Wheatie. So I want knife, Bovie. You guys ready?
Somebody can pull the
So I could feel the generator here. And we're gonna go from there to there.
lab, wet lab.
Take.
Thank you. Please. Thank you. The retractor is ready, Oscar.
I get really scraping the generator right there. All right,
Okay, you ready? Scissors ready, please.
there we go. You guys see that?
Yes, we do.
Pretty cool, huh? So we got the Nervo Senza. And is this what you want? Huh, folks? You want that thing in your body? It's a simple question answer. Henry, you want this in your body right there?
No.
With wires connecting to your spine?
I
This is the
nope.
shit they're putting in people these days. Yeah, scissor.
this. Yeah. Somebody pull the laser fire, please. Thank you.
All right, well. I couldn't get the leads all the way out. They were pulling on the spine area, and I don't want to hurt her. So, yeah. There it is. I'm going to start with a deep closure. So what I'm doing is I'm bringing...
Can you put some Vanco there? I'm sorry.
Uh-huh.
Do you want me to irrigate a little bit? What happened?
No, it looks clean. Here, put a little bank in there if you want. Oh, no.
Just a little bit?
Let me see how we can get that in there.
I have irrigation with Vanco if you want to irrigate.
Yeah, we can do a little irrigation.
If you want to actually have Vanco.
Uh-huh.
I need more, please. More.
There's no bleeding, so we're okay. Let me see this. I'm going to put a little antibiotic in there. Just because we don't want any infections. All right. So. Sis, go ahead and cut it. All right, so that brought the pocket together. The pocket is deep. You want the pocket closed with suture, because if you don't do that, what's going to happen is the patient's going to potentially develop a seroma in there, like a big fluid collection. Then it can get infected. You don't want that. Any questions?
No current question.
We can
See,
start counting if you want, Sarah.
I still know how to sew, even though in endoscopic surgery you really don't need to sew.
I have a right over here.
Many years of sewing in the hospital, so many open surgeries. What is it?
Scratch pad still over here. Working on the field. You want scratch pad?
See how we have the cross hatches, folks? Luis put those there. That way we can bring the skin edges back together the way they're supposed to be, lined up. If you don't do that, you're going to get what's called a dog ear. And a dog ear is not something cute and nice. You want to take that? A dog ear is when the skin folds on itself and it creates something that you don't want. I'll show it to you. The dog ear is when the skin is like that. See that? That's the dog ear. This is a no dog ear zone. We like dogs. We don't like dog ears.
You can relax on the rackets.
Just about done. And then you're gonna do steri strips?
Yes, sir. Yeah.
I would.
I cover with this one.
Uh-huh. Any questions?
No current questions.
Oh, by the way, she's from Michigan, right?
No, Wisconsin.
Sorry, Wisconsin. Oh my gosh, they'll kill me if I apologize. I meant Wisconsin. The cheese state. You know, we've raced go-karts there and cars. So I'm doing this so I'm done. I'm doing this so that you're going to put one on the others.
Yes, sir.
And you know how to cut it, right? So it's straight up, down, so there's no tail. Great job, guys. Great job, everybody. Good job, Oscar. Thank you. Good job on the laser. Everybody did a wonderful job today. I'm going to go check on our last patient and say goodbye to her. Just go ahead and run a testimonial, and I'll be right there.
And I'm Dr. R. Dugmajan here at the Duke Spine Institute. I'm smiling because I'm sitting with my first surgical patient of 2023. I don't know if you realize that, but you were the first one of this year, of the new year. Now, you had the Duke laser disc repair done on your lower back because you had 3 bad discs, and we did that yesterday.
Yesterday, yes.
And here you are, one day later. How do you feel?
And I feel good. I feel good, and the pain that I've been suffering for months is gone. I mean, I was a little bit sore, but that's from the surgery itself.
Yeah.
But otherwise, I feel good. Feel good.
Now, you've had back pain too, on and off for 30 years. We were talking about that. Tell us about those episodes of back pain. What do they do to you?
The first one that I recall was pulling out a sofa bed thing. And I got so far with it, you know, we had company and I was opening up the bed, and all of a sudden I just could not move. I couldn't move. My husband had to practically carry me. So I was out of work for a week or so, and then at the chiropractor, and then gradually it got better, and I thought, well, that's fine. And I moved on, and then, you know, had a couple other times like that. One time I was drying my hair, getting ready for work, with the blow dryer going like this with my hair, and all of a sudden, it's like I couldn't move. I couldn't move my arm down. I couldn't, I mean, it was that quick.
Yeah.
And just, I was out again for another week, laying in the bed and doing all that stuff. And then I thought I was fine, but I always, not always, but for many years now, probably at least those 30, I had lower back pain, where in the morning I couldn't bend over to brush my teeth. You know, that would really hurt.
Yes.
So I had that.
Do you have that pain now?
No, I don't think so.
It's gone.
The pain this morning, I was the first time in a long time I've gotten up first thing in the morning and was able to walk and not have that awful pain, because first thing in the mornings was the toughest.
I'm so happy for you. So how is this surgery going to help you in your life?
Well, hopefully I can, once I can at least walk again. I was not able to barely walk with a walker. I was very active in my church and my community.
So you want to get active again?
And being in such pain now since July, and this is the new year, I'm anxious to get back to, you know, my life.
Yes, of course. Well, you had 3 herniated discs in your lower back, and you can see in the footage where we went into each of those 3 discs, and I used a laser to clean the tear, where you had a tear in the back of each of those discs called an annular tear, and the jelly from the center was stuck in the tear, holding it open, allowing more herniations to come out. So I got rid of the jelly that was in there using the laser, cleaned out the tear, and now your body will be able to heal that for the first time in 30 years. So I don't expect you to ever have that pain ever again.
Thank you.
You're welcome.
I am so thankful.
Well, you had faith, and you found us.
Yes, I did.
You did what's right for your body, and I'm excited for you. So
I believe I did. I just kind of was led to you, and it just all went bing, bang, boom, and I didn't ask a whole lot of other people what they thought. I just did what I thought was I needed to do.
Good.
For me.
Is there anything you want to say to your fans out there?
I would recommend that if you do something to your back, that you take care of it early on. You take care of it right away. The longer you wait, the harder it is and the longer it takes.
It takes a toll on your life.
Oh, definitely. It has taken a toll on mine since this summer, for sure, where I have not been able to, sometimes not function at all, barely be able to sit in a chair and be comfortable without squirming, because I couldn't find that exact place where I didn't have pain. You know?
I don't see you squirming anymore.
No, I'm not squirming. I know. That's great. Sit here without pain.
Congratulations.
Thanks to you.
All right, have a blessed day.
Thank you. You do as well.
This is Dr. Aru Duke-Majan, CEO and founder of the Duke Spine Institute. I'm here with one of my patients, and you've traveled from where to the Duke Spine?
Idaho.
Idaho, with your lovely husband, and we've had a few conversations. She came here to have her back fixed. How long have you had back pain for?
For over 7 years.
Okay. And what kind of work did you do before you retired, if you don't mind me asking?
It was desk work.
All right. And so you had back pain for 7 years. Did you have an injury to your back, or did it just kind of gradually come on?
It just gradually came on. I actually noticed it first in 2015 when I was gardening and I couldn't be up there for 8 hours. I was into it for about 4 hours and I had to take a break. And as time progressed, my breaks got longer and longer, and the amount of work I did in the garden was less and less.
Understood. And you're retired now. So what's it like having back pain limit your ability to do stuff when you're retired?
For me, it's very frustrating. I can't do that what I want to do. So we kept seeking solutions and nothing was working. They did work for a short while, but that short while decreased over time. It was shorter and shorter. My husband does research very, very well. Through his research, he found you. We read that you can fix my back, and you did fix my back.
That's right.
And I thank you.
You're welcome. So when did you have the Duke laser disc repair done and the Duke plasma rhizotomy?
I had those done yesterday in the afternoon. I am sitting straighter than I have. I'm standing straighter. I'm walking normal. It's like, wow, new me.
Look at that smile right there. I hadn't seen that until just now. So
well, it wasn't there yesterday.
Yeah, it wasn't there before surgery. And how long have you been not smiling because you've been in pain? I mean, really bad pain. How long has the really bad pain been there?
Well, the really bad pain has probably been over the last 5 years. It's something that was really tough to maintain a positive attitude and try to keep a smile on my face and keep Jeff's hopes up. I tend to be a positive person, but there were times when it does drag you down.
Of course, yeah. It's hard living with chronic pain, and especially with loved ones, they have a hard time, relating. Of course, they want to be supportive, and your husband is a very supportive man, obviously. And he's a pleasure to meet. I know he's an author as well.
Yes.
And so what are you going to do now that you've had the surgery? And you could see actually the Duke laser disc repair procedure she had done yesterday. You can see right here, we went into the discs that were damaged. You had 2 annular tears. We tested your discs during the surgery, and indeed they were causing your pain. So we verified that with our discogram. And then I went ahead and used the laser to clean up the tears that were causing your pain and get rid of that source of pain for you. And here you are, you're doing fantastic. How much of your back pain from before surgery do you still have?
Oh, virtually nothing.
It's gone.
It's gone.
Cured.
My lower back, I have not been without pain in my lower back until your surgery. It's constant, it's always there. I've never been without it. I'm without it now.
So are you going to go back to gardening?
You bet I am.
All right, very good. And what other things would you like to do now that you have a new back that doesn't hurt you anymore?
The biggest thing I want to do, I want to go fly a kite.
Good for you. Let's go fly a kite then.
That's right.
Well, congratulations on having faith
Oh,
and being
thank
brave
you.
and getting it done.
No, not a problem.
Is there anything else you want to say to your fans out there?
I highly recommend Dr. Duke's Spine Institute, Dr. Duke personally, to help you fix your back.
Thank you. Appreciate that. All right. Safe travels.
Phew, that wasn't too bad, was it?
It was wonderful. And good morning, I'm Dr. Duke-Majan. I'm here with one of my lovely patients from Canada who's visited us because her back has been hurting for 7 years. She's had a herniated disc that she's been kind of monitoring at L5-S1. And finally, it really started bothering her a lot over the last 7 months to a year, causing pain down into her right leg. So she decided to do something about it, and she went to see her doctor in Canada. who then said, yeah, I'll have you see the specialist in 3.5 years. Well, that wasn't going to work for you, right?
No.
Yeah, because you don't want to live in pain for 3.5 more years. And even then, you don't know what you're going to be offered. But she found the Duke Spine Institute and learned about the Duke laser disc repair, endoscopic surgery, and you had it done yesterday.
Yes, yeah.
How are you doing?
I'm feeling great today. I have no pain in my back. I have some tight muscles from me having to walk very oddly for quite a while due to the sciatic pain. I must say, this is the happiest I've been in a very long time to be able to stand up straight and go for a walk. Because I'm an active person as is. I ride horses for a living, so having to be locked up in my room for the past while has not been good. So this has felt amazing, amazing.
So you're happy with the results?
Very. I feel very hopeful also to be able to do what I want to for the rest of my life.
Yeah, after we let the disc heal, right?
Yes, full year of nothing, and then we can.
Yeah, I wouldn't say nothing, but you know, horseback riding, it's one of those things where I love horses and I love riding horses. I'm not very good at it, but I'm one of those people you see bouncing up and down, up in the saddle. So I know that it can be rough on your back, and I just want to make sure you give your back a full year to heal. So you can see in your surgery right here, we actually tested your L5-S1 disc with a discogram, which is a test done to verify that that disc is indeed causing your back pain. And when we tested it, you said, and we asked you how bad it was. You said 10 out of 10 pain. And I said, is that your typical pain you get every day? And you said, yes, it is. So we verified the source of your pain was the L5-S1, and you can see the laser was used to clean the tear endoscopically. Your incision was only 1/4 inch, and there's no need for fusion or metal or artificial discs. This surgery replaces fusion and artificial discs. What are you going to do now that you're feeling better?
Well, it's, again, don't worry, I will take it easy, I promise. But no, I'm going to be, after this, this year, I hope to be the strongest I've ever been, and I have very high hopes and whatnot. My dream is to make actually the Canadian Olympic team for my sport, and that's end goal, and I feel like it's a possibility now.
Absolutely.
To do it.
You can.
Yeah.
We're rooting for you. And I know you have an incredibly supportive husband who's been by your side the whole time. He's a delightful young man, and I've had time to talk to him as well. So you're lucky you have support from your family to help you get through this.
Yeah.
Anything you want to say to your fans out there?
Oh, geez, I don't even know where to start other than just this place really can offer you really what either you deserve or what you need going forward to be able to live a happy and good life. And it's amazing to me that literally it was yesterday I woke up from it and I went for a short walk like immediately, and I felt amazing. So it's it's very hopeful, and if you are suffering from any of it, don't wait, especially for the Canadian system. Come and do this. It's worth it. It's really worth it.
Awesome. And I'm going to be, and my whole team is going to be watching the equestrian sports in the Olympics, looking to see for you to be there.
Yes.
All right.
Awesome.
And
Amazing.
of course, supporting you.
Thank you. Yeah.
All right. Congratulations.
Thank you.
All right. Take care. All right, I'm here with one of my patients who traveled from Australia to Florida to the Duke Spine Institute for treatment. And you look happy today.
Yeah.
Yeah? Why are you so happy?
I'm happy because my back pain is gone.
Your back pain is
and
gone.
my leg pain is gone
Awesome.
from the disc. Yeah.
From the surgery yesterday.
Surgery yesterday. Yeah.
And you had the Duke laser disc repair.
I had the Duke laser disc repair. Yeah, that's right. Yeah.
So why did you come all the way to Florida from Australia for the Duke laser disc repair?
I've been suffering from back pain and leg pain for nearly a year after an accident. So I did a lot of conservative treatment like physiotherapy, exercise physiology, but it hasn't cured my pain. The pain was chronic, and I've been suffering from a lot of issues, emotional frustrations and things, and sleepless nights. But a couple of neurosurgeons back in.
Hi there. Dr. Duke Machen joining you, and just came out of the operating room where you saw me just a few minutes ago fixing 2 herniated discs. This poor lady, she comes from Wisconsin with her husband. They traveled to Duke Spine because she's having a horrible pain in her back. She had a fusion done, and just right next to that fusion, we call that adjacent segment, she got more pain in those 2 discs above her fusion. That's very common. Problem with fusions, folks, is that to do a fusion, a surgeon has to really destroy things around the spine, normal things like muscles and joints and tendons and ligaments, and by removing all that stuff or damaging it with the fusion surgery, that's just going to make the other parts of your spine wear out faster and start causing pain. And we call that adjacent segment disease. Now, it turns out that it happens with fusions, but it also happens with artificial discs. And as a matter of fact, they just discovered that it happens the same if you have artificial discs and you have fusion. Don't matter. The rate of adjacent segment disease is the same. Now, adjacent segment disease is when you wear out the discs above or below your fusion and they actually cause symptoms or pain. We call that disease. It's normal to find spines with degenerated discs. And what I mean by that, not normal as in it's normal to have a degenerated disc, but it's normal to find people with degenerated discs that don't have any symptoms, all right? And in that case, they have disc degeneration, but not disc disease. The difference is symptoms. If you don't have any symptoms, you don't have disease. So for this patient, somebody up in Wisconsin did a bunch of surgeries on her back. They did laminectomy, microdiscectomy, fusions, and she had screws and rods. And she had that cages that were put in through the front. She had screws and rods in the back. It makes me so angry and so disappointed to see people like this who are taken advantage of by these spine surgeons that just are doing barbaric surgeries that create the need for more surgery. In the end, she ended up getting a spinal cord stimulator, which didn't even work for her. She had it off for a couple of years, and I told her test it and make sure it's not working. She did that, and she said it doesn't help. So she wanted me to take it out. And as with most spinal cord stimulators, there's so much scar tissue where the leads are, you can't pull them out because you might damage the person's spinal cord or cause a spinal fluid leak or something bad. So I got the generator out real easy, but then I started pulling on the cables and I couldn't get them loose. So I ended up having to cut them. But the good news is, with that thing out, she can now have no more pain where the generator is, because that's right where she was laying on her back. It was sore. Now that soreness will go away. Also, because we got it out, she can now have an MRI scan, okay? And by getting the MRI scan, she can check things in her back and make sure everything looks good. And but anyway, the surgery went well, didn't have any problems. So we did 3 things. We fixed 2 discs, and we took out a spinal cord stimulator generator. Any questions?
Yes, we have a question just added from Miran on
Hi,
Facebook.
Miran.
And they asked, in fusions, you have to remove part of the ligament besides the disc? That's where instability starts, as I understand it.
Yes, Miran. So the problem with fusions, and I'm going to tell you, every surgeon does fusion differently. And, you know, that's just the fact. There are fusions that are done through the front. So if you go through the front, you're going to take out the anterior longitudinal ligament. Then you got to clean out the disc. Then you got to put a cage in through the front. That's what this lady had done at 2 discs, 4551. Then they flipped her over and they went in the back and they put screws and rods through the back. So she had a front back with 2 separate incisions, a front and a back. What I do my fusions all through the back. I take the bones and ligaments out in the back. I put the cage in through the back side, called the transforaminal lumbar interbody fusion, or TLIF. And then I put the screws and rods in and I do a fusion in the back. So that's a 360 fusion where you go anterior posterior. It's a combined anterior posterior. It's, in my opinion, the best and the safest. And then there's fusions where you can just go in the back or you can go in the side, going through the iliopsoas muscle. I don't recommend that. A lot of people have weakness in their legs for a long time, sometimes permanently. There's so many problems with fusions where the surgeons are destroying the normal architecture of the spine, and that creates instability at the segments above and below the fusion, and that's why patients go on to have and need more fusions and more fusions and more fusions. And it's a crying shame because all that can be avoided with the surgery you just watched today, the Duke laser disc repair. In the history of doing this surgery, I've done for 16 years, over 1,600 patients, I've not had to do a single lumbar fusion on a patient because it didn't work, okay? It always works. The only thing is that people get pain sometimes from other things like facet joints or the piriformis. To give you an idea of what a facet joint is, this is the disc here, this big thing between the two bones. The facet joint is in the back, it's right there. And we don't treat that with the Duke laser disc repair, we treat that with the Duke plasma rhizotomy. So it's a completely different procedure for a different kind of pain. Any other questions? Well, thanks for joining us. That's the last surgery for today. Today took us a little longer than expected. Our first patient is just about ready to leave. She's doing very well. And this last lady, we're going to get her out of the operating room, wake her up. She'll go home today as well. Both of these surgeries were done outpatient. There's no hospitalization needed. And as somebody mentioned earlier about transfusions, we've never had to do a blood transfusion. It's just not necessary. We lose maybe 5 cc's of blood. You need to lose not 5, not even 50, not even 500, but around 1,500 to 2,000. So you need to lose 400 times as much blood as what we lose to need a transfusion. So the Duke laser disc repair doesn't require transfusions, and there's really no blood loss. All right, I hope you had a great day and learned something, and it's been my pleasure spending time with you and teaching you today. I'm Dr. Duke Majan, CEO